Hi, hello. My name is Romer Greco G. Geocadin, and I'm a professor here at Johns Hopkins in the Department of Neurology, Department of Anesthesiology, Critical Care, and Department of Neurosurgery. I'm also a neurointensivist in the neurocritical care units at Johns Hopkins Hospital and Johns Hopkins Bayview Medical Center. In this particular part of my work, I was actually the chairman of the writing committee of the American Heart Association Emergency Cardiovascular Committee that came up with a scientific statement that focused on the standards for the studies on neurological prognostication in comatose survivors after cardiac arrest. The goal of the American Heart Association is to improve the outcomes of patients who suffer from cardiac arrest. And over the decades, we have noticed that there is a steady improvement in the way people are successfully resuscitated. But when we actually look at the actual outcomes of what happens to those people that have been resuscitated, meaning that their pulse come back, the actual numbers of people who actually have successfully returned to their level of functioning are still very low. And then we tried to see what were the things that were leading to this. And then that's when we realized that the majority of the patients that were resuscitated after cardiac arrest are in what we call a comatose state. And that's when we know that the patient's injury, even if their heart has come back, is primarily with their brain. In this setting, what happens is that the people are totally comatose, meaning they're unresponsive, and even if their heart, their kidney, their lungs, and most of their other organ systems are back and functioning adequately, the brain is still out. And so when we looked at this carefully, while there is a great consideration that the brain is injured, when we looked at the actual cause of death, only 10% and less of patients actually are really dying of brain death. But the surprising thing, which is the concerning thing for us, was that the vast majority of people who died as a consequence of withdrawal of life support. And by withdrawal of life support, what that means is that there is a process that is undertaken whereby the family and the patients and the doctors will evaluate the patient and will predict the likely outcome of that patient. And typically when the prediction has come to a point that the patient is not going to wake up, the family and the doctors will decide to stop life support or life-sustaining therapies. So the patient dies. So when you really think about it carefully, it's not really the disease process that kills the patient directly at that point. There is a big influence of the bias or of the prediction that happens leading to that decision to stop the ventilator and stop the other things that we're providing to sustain the life of the patient. Because of this, we started looking carefully at what were the things that we could improve in terms of the prediction process. And that's when we realized that the quality of studies out there that describe the process of prediction has very low quality. Many of them are not controlled. Many of them are done still with a lot of confounders from drugs that are given to patients. And many of the studies do not have a standard time whereby the decisions are made. And all of these studies get published into the literature, get cited, and get used. So there is the big danger that in many of these patients, we are predicting patients who will do poorly but still has a chance to do fine. But on the other hand, the flip side to that is there's also a risk whereby we will say that the patient will do fine for a long time, but in fact they will not. So we want to make sure that the science behind this is improved such that the care that we provide to the patients will be better in terms that we have a better ability from a science perspective to really identify which of those patients will survive and have a good quality of life and which of those patients will not survive and will just suffer for a long, long time. So with this, we actually came up with this solution that maybe what we needed was to come up with the best recommendations and best evidence on how to do these studies. This is not the first time, because when we look at the other fields, other areas in medicine, they've come up with requirements and criteria on how to do this. And following the trend in some areas, this is when we coming up with a recommendation that will define the standards for how to do this. So we made specific recommendations on what the studies ought to be, and the group that actually was convened by the American Heart Association is an international group that is made up of very established and seasoned experts in this area that come from neurology, which are brain specialists, that come from cardiology, the heart specialist, emergency medicine, the doctors who resuscitate during the emergency period, and also internal medicine doctors, as well as nurses. And then we have included also pediatricians that cover the brain, the ICU, as well as the emergency care of children. So this statement covers the standards that will guide, that will hopefully serve as a roadmap on how to do the prediction studies or the prognostication studies when patients are resuscitated and they remain comatose after cardiac arrest. So I just discussed a little bit about the impact on patient care and the decision that we make at the bedside for the patients and their families. The other impact of a prognostication study that is not well done is on the science and on the research that we do. Because when we look at the clinical trials, many of the clinical trials actually are dependent on what happens to the patients. So for example, if we give a drug right after we resuscitate them, we look at the outcome on the impact of that drug many days, weeks, typically 90 days, 30 to 90 days after we give the drug, and see whether the drug was effective or not. What we are observing in many of these cases is that many of the patients are predicted to have a poor outcome, and therefore their life support is withdrawn at day 3. So therefore, we are not able to see the actual effect of the drug. And because those patients died, all the causes of death in many of these cases are lumped together as death. So we are not able to understand the actual effect of that drug, because if the patient died, we will say that that drug was ineffective. But when we really carefully analyze it, we've not given that drug the period to have its effect. It was a premature time whereby we actually stopped care for the patient. And so because of this, because we count all deaths as the same, we make the judgment that the drug failed or the intervention failed. So therefore, the science is also suffering from this, because what we're really looking at is we are really disadvantaged because the science that we're using to predict is low quality. And the consequence to that is that the trials that we do are also influenced by the low quality prediction. So therefore, most of the drugs that we've tried in this area were subjected to that bias. So this is the other big motivation why the subcommittee did this, and the writing group also wanted to see that if we change this and define it better, we will be able to see the effect of the drugs that we're studying in a better way and really capture the effect that we want for these drugs. And hopefully in the long run, this will help not only the studies that we do, but also provide better treatments for these patients that are really, really needing interventions at this point. Thank you.